Good evening, everyone. Good afternoon, good morning, depending on where you're joining from. Apologies for the delay. We had some issues getting our guests on this space, but that has been sorted now. So thank you so much for joining today. My name is Oreoluwa Olukorode. I am the operations manager of Stats Clinic, and I'll be moderating today's conversation. If you can hear me, kindly respond with an emoji. All right, thank you. Thank you very much. So today we have a very amazing guest in our midst. But first, let me introduce what this session is about. So this session is part of a new initiative by Stats Clinic, where we are creating spaces for meaningful conversations around research. Well, we plan on inviting researchers who are doing impactful work to give some insight into their journey, the work that they are doing, especially for early career researchers, clinicians, and students who are part of our community. So if you are just joining, don't forget to follow Stats Clinic so that you don't miss future sessions. So, like I said earlier, we are joined today by an amazing person. Her name is Professor Bosede Afolabi. This is our first ever community talk, so we are super excited to have such a distinguished guest in our midst. So the first time I met Prof. Bosede Afolabi, I didn't meet her personally, but I was in the same room with her. That was 2023 during a closed door meeting hosted by the On Time Consortium and the Lagos State Ministry of Health. And then I met her earlier this year at a health tracker event called Banking on Women's Health Conference, where she spoke about the importance of research in women's health and, the work that she was doing, on maternal health. So today we have Professor Bosede Afolabi. Ma, if you can hear us, can you unmute your mic to say a few words?
Good evening, Ore, and thank you so much for introducing me so nicely. I'm very happy to be here. I hope I'll be able to impact some of the people listening and that we will have a good discussion. Thank you.
All right, thank you, Ma. So just a brief intro. Professor Bosede Afolabi is a professor of obstetrics and gynecology at the College of Medicine, University of Lagos, and she's a leading maternal medicine expert. She holds a doctorate degree in medicine from the University of Nottingham, United Kingdom, and she's also an internationally recognized researcher, especially for her work on sickle cell disease and anemia in pregnancy. She's a fellow of several prestigious academies and professional bodies, and she has led major research projects funded by TED Fund, NIH, the Gates Foundation, and so many other prominent bodies. She's the director of the Center for Clinical Trials and Implementation Science, and she supervises PhD students and mentors emerging and also emerging researchers. She has over 130 publications and 7,000 citations. That is huge. And she serves on multiple editorial boards. She has received so many awards, and she has been featured on CNN also. So thank you so much for joining us once again, Ma. So we get right into the conversation for today. And this conversation is going to focus on one of our Prof's major research projects, the IVON PP Trial. So this trial addresses a critical issue in maternal health, and we are excited to, learn about the process, the findings, and just get general insights on this project. So to start off, Prof, would like to hear from you. Could you give us like an overview of this IVON PP trial? What is it about? Just to give more context to the conversation.
Thank you, Ore. So the IVON PP trial was actually a follow-up to the IVON trial. And basically, IVON stands for intravenous iron versus oral iron for anemia in pregnancy. We took certain parts of it to make the acronym. And that was IVON. And then after we completed that particular trial, we now moved on to the IVON PP trial, which was now done for women who had just delivered their babies. The background to it all is that anemia in pregnancy is quite common in our environment. Approximately 50% on average, although in some areas it's even more common. Now, after having your baby, it's actually even more because women do bleed during childbirth. And when they're pregnant, some of them may not even have had enough iron and they may be anemic during the pregnancy. So with the additional bleeding at childbirth, they get even more anemic. Anemia, as I'm sure a lot of people would have guessed by now, if they didn't know already, refers to a reduction in the blood, specifically to do with the red blood cells, the part of the blood that carries oxygen. And so if you have anemia, there are a lot of things that can happen to you even when you're not pregnant. You are more prone to infections, you're not more prone to feeling weak, you're more prone to a lot of negative things. So you can imagine when you're pregnant, if you now develop anemia, or you have anemia when you enter pregnancy, the risks to yourself and your baby are significant. Anemia is actually known to cause maternal death, especially when it's severe. It also leads to the risk of bleeding more when you are having your baby, and it's linked with depression in pregnancy, linked with depression postpartum, that is after delivery. It's linked to having more infections, linked to your wound not healing properly. So after we carried out and it's also linked to the babies not developing properly during pregnancy and possibly not bonding well with their mothers after delivery if the woman is anemic then. So after we finished the pregnancy trial, the one we called IVON, we went on to do the one for women who had just had their babies. And that's the one we called IVON PP, PP standing for postpartum. And in this particular case, what we did was the question we were trying to answer was whether intravenous iron, a type of iron preparation which you give through a drip infusion, we wanted to find out if that sort of preparation was preferable or was more effective than tablets, iron tablets in treating the anemia and also in preventing some of the complications that we knew that anemia causes, and finally to be sure that it's safe. Now, backing down to the reason why we're looking at iron, most of the anemia in pregnancy, a large proportion of the anemia in pregnancy, as well as after delivery, is due to iron deficiency, which is why whenever a pregnant woman goes to the hospital, to the clinic, she tends to be given iron tablets. So that is why we were looking at the iron. And the reason why we're looking at intravenous iron, that is iron that is given through a drip, is because we know that even though tablet iron works, in some cases, iron tablets, one, either do not work for some women because they don't absorb the tablets properly, the iron from the tablets properly through their intestines after swallowing the tablets. Or in some instances, even if they do absorb it, they don't like to take it because it tends to cause some side effects for some women. And so it can cause things like nausea and vomiting. It can cause things like constipation. Some people have diarrhea from it and stomach pain, which is why some people don't take these iron tablets when they're pregnant. Because of that, and because we know it sometimes also isn't absorbed, and because we know that anemia is such a serious problem, we tested to see if giving this iron as a drip form, just once, giving it once immediately after delivery in the drip form over 15 to 20 minutes, compared to the woman taking iron tablets for over 6 weeks, would be more effective. Immediately at that 6 weeks, to find out if the number of women with anemia at 6 weeks is lower in the intravenous iron group, or and also we even looked at it up to 6 months. And it was an interesting project. It was very, very interesting because as I'm saying it now, it sounds like, oh, wow, just a question, give an intervention, get the results, and you're okay. In this case, as in the case of every clinical trial, especially when it's phase 3, you have to recruit a very big number of women. Here we recruited 1,400 postpartum women that had just delivered across 4 Nigerian states in 20 facilities, which can be, things like that can be a nightmare for coordination. But we had some really good people who were able to ensure that we coordinated all these sites properly, and we were able to recruit the number of women we needed. Now, just recruiting them is not enough. You recruit them, you take their consents to either have this drip or take tablets. So what you do is that you randomize them into 2 groups, very, very randomly using computer-based software, randomization software, to try and ensure that each group is treated exactly the same way, except for the whether they're getting the drip or whether they're getting the oral tablets, and also to try and ensure that there's no bias in selecting these women. You're not selecting women that are coming to clinic together. You're not selecting women. Each woman, will not know what group she's going to until you've entered her details and you've enrolled her. So that's basically the background. I don't know if I should go on, Ore, talking about the other methods and the results, or if there were any other questions or anything I needed to say now. Thank you.
Thank you so much, Ma. You've given us, quite a number of details on the trial. Yes, I would like for you to go on, and I would also like for you to tell us the major challenge that you faced, because you said, you had to do this trial in 4 different states. You had to coordinate the women, So we want to know what major challenge you faced during this period, and how long did the trial take?
Thank you. The trial took close to 2 years in total, plus or minus. And there was also some additional time for the logistics. You have to give about 6 to 8 months even before you start to, getting your permissions. You can't just enter town and say you want to start a trial. I don't know who all my audience are, but if there are people that haven't done trials before, you know that your ethics is key. So First of all, you have to write to ethics committees, tell them what your trial is about, let them look through all your protocols and your pro formas and your case report forms and your consent forms to be sure that they are appropriate to, and safe for women, and that there are no ethical considerations to worry about. After you get those, and such things, you have to apply to everywhere that you're carrying out the trial. And you also have to apply to the National Health Research and Ethics Committees. So in IVON PP, we probably had at least 10 to 12 different ethics committees to address, because each state has its own. All the teaching hospitals had theirs, and then you also had the National HREC. Apart from that, we also had to apply to the NAFDAC, because it's not just when you want to, approve drugs. In this case, when you want to carry out a clinical trial, NAFDAC has to approve that you carry out that trial. And NAFDAC also has to approve the medication that you're using. And in this case, we didn't have FCM, that's the name of the intravenous iron. It's not something that is used regularly in Nigeria and not available. We had to import it. So NAFDAC had to verify and agree for that to happen. So the ethical part too was quite a challenge. It took time to complete all those all that paperwork. Then you have to design the case report forms. We have a very good data team. By the case report forms, I mean the places where you're going to enter the data for each of the different questions you're asking. So I mentioned of course, the blood tests. You have to have sections where you enter the blood test results. You have to areas where you have to enter the details of the women, their age, their how many babies they've had, their if they'd had any problems during pregnancy, where they live, so many different things. Then, apart from that, you also have to have areas where you record things like the other questions, the depression, the blood test results, the anemia, their blood level, the iron status, many different things. So that had to be created. And of course, we had to get the tablets, electronic tablets that the data was going to be entered in. Yeah, so there's a lot of procurements going on, things to do with measuring all the different things we want to measure, like weighing scales, blood pressure machines, things to to screen the women to recruit them in the first place, like your hemoglobinometer, which checks the hemoglobin level, the hemoglobin being what tells us whether a woman is anemic or not, by a finger prick method when you first recruit her in clinic. So many different tests that needed to be done. And so many things that needed to be done to prepare for those tests to be done. So the challenges were in getting all those different permissions and procurement. Now, when we actually started recruiting, recruitment is not itself an easy thing. We have also some very good trial managers as well as admin staff that help to ensure that this is done properly. But of course, they are in the center. Even though they go out to monitor, we also have to have people in the different states. So we had people, doctors and nurses in all the different institutions in all the different states, working. The nurses, most of the nurses were actually hired full time because of the trial. And sometimes some challenges, a nurse will not show up for work sometimes, or she has something else to do, or she decides that at that moment, maybe when you're about 6 months into the trial, that she's going to jackpot, because as you know, nurses are in great demand outside the country. So there are a lot of challenges like that. And when you actually recruit the women, sometimes, a few times, especially at the beginning of each trial, the woman, maybe if the people that are in that hospital are not very experienced with trials, they may be so happy to quickly rush and recruit the women. And then as soon as they have, the woman says, she didn't hear you properly. She's not interested anymore to go further. Or her husband, that one was quite a common thing at the beginning of our first trial. The husband saying, hey, trial, okay, never, you can't have that, even though the woman had already consented. So those are big challenges, especially in a society like ours that is very cultural and male oriented. So you have to have women, you have to make sure you carry the whole family along in terms of, recruiting the woman in the first place. So those are some of the challenges. The other methodological issues included the recruitment, the data entry, making sure that the data is correct and clear and clean, because sometimes some people can make mistakes. So data has to be clean to be, if all of a sudden you have somebody that is measuring 400 grams, and you know that 400 grams or 4,000 kilograms, they've entered it wrong, obviously. So some of those things have to be looked at as well. Safety issues, those are key, and we also monitored all those. One of the reasons why drip is not as if it's new that iron can be given in a drip form, but in the past, the old preparations that were available tended to cause certain reactions, which could be severe. So even though this new preparation is known to be very safe, we had to also be sure that it was truly safe. So we needed to monitor safety like you do in any other clinical trial, and make sure that the adverse events were well noted and carried out. So so those were the challenges, those were the efforts that were made. The other issue I forgot to mention is that in a lot of places, times when you don't know, you can't use the address to trace the woman. Remember that I said these women had to be followed up. So it's not just recruiting her once. She actually needs to be followed up. For IVON PP, we did delivery, then 2 weeks after delivery, 6 weeks after delivery, and 6 months after delivery. So you had to follow up the woman. There were about 4 time points that she had to be measured. And for those 4 time points, can imagine a woman 6 months after delivery. We managed to keep, getting to them and keep getting the data. We had over 95% retention rates, which is really, really good, because we had such dedicated trial managers and admin people who really followed up these people, these women. Now, in following them up, for the postpartum trial, what we decided was that instead of expecting them to come to hospital, we hired 2 nurses per institution so that they would follow them to their homes. So we gained consent even at the beginning for the women to be followed up to their homes so that they could track them. We call it tracking, track them to their homes, get the measurements, take the blood samples, do all that needs to be done, and ferry it back to hospital, because we needed to check if they were still anemic. Tracking is a major challenge. A lot of people don't necessarily have addresses to their homes. Even in Lagos, if you put my address in Google Maps, for example, sometimes it takes you to the right place. Other times it takes you to another street that sounds like mine, or the close as opposed to the street. So you can imagine in places where, you don't even have the luxury of having streets. What needed to be done is, as before the woman is discharged, the community tracker or the research nurse finds out where she lives, so that you can actually go back and, meet them at home. And those are some of the things we told the women at the beginning of the trial. What did we find? We found IVON PP was very fulfilling in that way. You always want your question to be answered positively in a clinical trial. It doesn't mean that if it's negative, you can't learn from it. And we do have some trials like that, which we have learned a great deal from. But for IVON PP, we found that women with moderate to severe anemia, that is, whose HB, whose hemoglobin level was less than 10. What is appropriate for pregnancy is for your hemoglobin level to be 11 and above. But in the women we recruited were women whose hemoglobin level was less than 10, which means they had moderate anemia, not even mild anemia. So we found that women with moderate anemia had their anemia corrected more effectively, quicker than when they had tablets. And this, as I said, was one single dose of this drug versus 6 weeks of taking these tablets. That's one. The second thing was that even up to 6 months, this greater effect persisted. So intravenous iron, this ferric carboxymaltose that you can give, we call it FCM, that you can give by drip just over 15 to 20 minutes to a woman, was more effective than the tablets, even up to 6 months when we monitored the women at 6 months. So as you know, in our environment, a lot of the time, women don't come to hospital. So if you can at least get them that one time after they've just delivered and give them this medication, then to a large extent you're preventing them from continuing to be anemic and having the problems that arise from anemia in between before, for up to 6 months. And as you know, some women don't do enough family planning and they get pregnant again, and that makes even the next pregnancy worse. So if you can give them this medication after pregnancy one time, you know that they may not come back to hospital, and it helps, treat their condition, then we felt that this was a really positive thing. So that's it. I think I've talked quite a lot. And yeah, those were the results that we found, that we answered that question. Intravenous iron was more effective and quicker to correct anemia than oral iron given for 6 weeks. Thank you.
Thank you so much, Ma. That was very, very, very detailed. So if you have questions, you can either leave them in the comments or write them down somewhere. We'll take a couple after this question and answer session. So you mentioned that you had to import the ferric carboxymaltose. I'm quite curious about the costs. Because in this our area in Nigeria especially, costs is one of the biggest drivers of our health seeking behavior. So comparing the cost of this intravenous iron to the regular oral ferrous sulfates, is there a significant gap? Is it an affordable option, despite being, the safer and the more effective option?
That's a very good question, Ore, and we anticipated that. So for even our first trial, we did what we called a cost effectiveness analysis of both the intravenous iron and the tablet. As you can imagine, without doubt, the intravenous iron will be more expensive than the tablets, especially because, tablets, you can buy them small, and for the intravenous iron, you buy it all at once and you bear that cost. So definitely, the intravenous iron is more expensive than the oral iron. Now, however, when you take into the added costs, so first of all, the intravenous iron had very minimal side effects. Meanwhile, the oral iron tablets, was the one that would cause diarrhea that ends some people up in hospital, just as an example. I'm not saying, please don't get me wrong. Tablets are still the first line. They're still, especially if you have mild anemia, it's still what you would give women. There's no need to be putting a drip, because with drip you have to put in a cannula into the veins. That's a plastic device into the veins to be able to feed the drip through. But with tablets, all you have to do is have some water and swallow it. So tablets are still the mainstay of treatment of mild anemia. However, when the anemia is no longer mild, it's become moderate, and it's also getting, to the middle of pregnancy where you know that, you don't have that much time. You want to make sure you correct this anemia before it can cause its complications both in the baby and in the mother. Then it is advisable to find something that can correct faster. And that's why the intravenous iron is there. So with the issue with the intravenous iron and the tablets is that the intravenous iron causes fewer side effects, and in fact you can actually the added costs for the intravenous iron are not as much as that for the tablets. The cost effectiveness analysis anyway found the intravenous iron to be cost effective. It was more expensive for sure, but it was definitely cost effective when taking all the parts of the woman having to come to hospital, they lost time for her, for work, they lost time for the caregivers, the possibility of transfusion reaction if you took blood instead of the intravenous iron, the possibility of infections from the blood, so many different things found the intravenous iron to be cost effective. Now, when we got it for the trial, bringing it from India, which was where we got it from, it was much more expensive. But now it's actually even come down, and we used the cost of the first Indian purchase to do the cost effectiveness analysis. Now it is a quarter, less than a quarter of what we got it from then in terms of some of the projects we want to do now. So it makes it even clearer that it is definitely cost effective. Thank you. Over.
All right, man. Thank you so much for that response. So yes, intravenous iron is safer, more effective, although slightly more expensive. Thank you for being very honest with your response. Okay, so in the course of the conversation, you talked about the challenges that you faced, and we know that conducting a clinical trial is not an easy thing, from the preclinical phase to the several other phases. And we know that one challenge that many researchers face is ensuring that, after putting in so much effort into your research, it actually translates into real change, in the real world. So once a clinical trial is completed, like this one, how do you navigate the path from, publishing your findings to influencing government policy or adoption? So what are the steps needed to ensure that what you're doing actually translates into routine practice?
Thank you for that. That's one of the areas we dwell on in TC organization, because it's not just a center for clinical trials, but the RIS is research and implementation science. Implementation science is the aspect of research that deals with the um, linkage between the evidence being generated by a clinical trial and the evidence actually being used at the bedside, approved to be used by the policymakers, and then eventually being used at the bedside by the providers. So if you just finish a trial and leave what you've done, on the shelf in the publication, then at the end of the day, you haven't really done that much service. Of course, you've done your own bit, but if you can close the gap by not only completing the trial, but ensuring that what you found gets used by the bedside, then that's an even greater achievement. And that's what implementation science does. It studies a lot of aspects of ensuring that the evidence that is gained is actually applied. And in the past, things were so bad that between evidence being generated and between that evidence being used at the bedside, it took sometimes up to 17 years. But that's not the case for a lot of things. So when we started the IVON trial, not only did we design a trial, we also designed an implementation science component at the same time, so that as soon as possible after, we would be able to get this medication to the bedside. And we've been working on it, and hopefully this should happen soon. Thank you.
All right, man. Thank you very much. So to confirm from what you said, are you saying that you've not been able to fully adopt this the results from this trial into like the clinics, the hospitals? Are you currently in the waiting phase? I'm not sure I got that.
Yeah, what you asked me was how how does it work to make it used, and I explained that. But specifically about ours, we first of all we just got our first set of data for IVON, I think in 2023. So since then, we've been working on putting that across. The problem is that it's not just any intravenous iron. It is an intravenous iron called ferric carboxymaltose, which is not being manufactured in Nigeria and is not even available, really. It's not being sold. So part of what we're doing is advocating for that. We actually even had meetings with the essential medicines list recently so that they can get it in there. And we are, working with people who are working with NAFDAC to try and ensure that it's also registered with them. So it is an ongoing conversation, but I think by next year, for sure, we'll definitely get it there, which would have been 2 to 3 years, which isn't bad at all in terms of evidence to policy. There's a lot that has to be cracked, but luckily, because of the weight of our evidence, because of the advocacy thus far, we should be able to crack it. It's also for the fact that we did a cost effectiveness analysis was a good thing, because if we hadn't, we won't crack it for another 5 years at the very least, because that's what everybody wants to know first of all. And all these things, there's so many moving parts that are relevant and important for you to be able to get these things to the table. So with our particular intervention, it's not just an intravenous iron, it's called ferric carboxymaltose, FCM for short. We're close to getting it to actually being used in Nigeria. Thank you. Over.
All right, man. Thank you for the clarification. So I'd like to zoom out a bit and talk about research in a more broad manner. So many researchers struggle with securing funding for their trials and other projects. What has your funding journey been like? And specifically to this project, how did you choose the international collaborator that you use, or the funding body that you use, or did they choose you? So we want to know how you
How did
decide
I choose?
to
Does
how you
anybody
decide,
choose their
bro.
funders? That's funny. I have to laugh there, because I can imagine if I just, had the luxury of having, 6 funders lined up and saying, no, I don't want your own funding. It's this one that I want, and they're ready to give you. I'm just kidding and teasing you. So basically, the journey to being funded for research is very long and arduous and tough for everybody. And it's one of the stories I tell when I'm doing any presentation on the journey of Sisyphus. It involves the fact that at the beginning, we didn't even know that we were supposed to try and look for funding, outside funding for research. I mean, it wasn't obviously available. So what we just used to do was, look for studies we could do easily with our own funds, So in fact, some people used to do just simple prevalence studies to get by. Some of us would decide, okay, we're going to see if certain analytes from some women with a particular condition were different from the same analytes in some women without the condition, and seeing comparative analysis, although also just taking all their samples at the same time, which we call a cross-sectional study. So a lot of the time, people were doing mainly cross-sectional studies, self-funded, and this was how we also started. But as time started going on, when I realized that if I wanted to do good quality research, I had to move on to, I mean, there's nothing wrong with cross-sectional studies, but they need to be able to answer the question you want to answer appropriately with the appropriate sample size. So I had to try and actually craft and design studies better. And then I now thought to myself, okay, I was already a lecturer, I was already a gynecologist, I already had my fellowship. How can I improve myself to be able to do higher quality research? I could have done it without going to do the doctorate, One of the reasons I did the doctorate in medicine as well was, one, to get the additional skills, but also to get the visibility in order to attract some of these grants and funding. So I did that. In my own case, that was my own path. It was after getting that and getting into some other projects and so on that I had the visibility from the CNN interview that you mentioned earlier on, and all those things just opened doors. Having said that, my first few grant applications were also, rejected. That's the norm. That always happens. But one of the ones that was relatively easy was the one from Unilag. And that's one thing that people should do first. If you're going to apply for funding, don't be applying for $100,000 funding as your first application. 9 times out of 10, in fact, probably 10 out of 10 as your first is not likely to go through. You'll be extremely lucky to get it. It's better to apply for small pots of money to start with. $2,000, $5,000. Do the work properly. Design the grants properly. Design the question properly, regardless of the amount you're getting. Use it well, and that, helps move you on to greater things. That's very important because they will see that you have got a grant, no matter how small. You collaborate with people who have done similar good work, and things get improved from there. So my first grant was a University of Lagos grant. At the time, it was about 2.5 million naira, which was actually equivalent to about $10,000 at the time. So that wasn't bad. That was not bad funding. In 2004, I think it was, that we applied for that grant. And that was one of the things I used to work on the question for my doctorate thesis, which was in sickle cell anemia pregnancy. And with time, went on applying for grants, got some, didn't get some, collaborated with others, and that's the other thing we mustn't forget that we must always do. Collaboration just helps. Collaboration, other colleagues from other disciplines. It doesn't even have to be medicine. Your question can be answered in so many different ways. And so within the medical field, other specialties outside the medical field, we have sociologists working with us as it is in CC3s, and pharmaceutical and people from the Faculty of Pharmacy. So all these different collaborations also help. Then after that, the collaborations eventually was able to be a co-investigator on an NIH grant, which was really big, and it was a capacity development grant. Got some more training in epidemiology and biostatistics at that point. You have to keep improving yourself. You have to keep improving your knowledge. Let it help, hone your skills. It lets other people know what you can do. It helps you do your work with better quality. And eventually, applied for the TED Fund grant, and was able to get it built off the back of some of the work that I had done for my doctoral thesis, as well as subsequent work after that, trying to just answer the questions from that paper or from that thesis. Attracting funding is hard work. And I'm talking about a 21 year journey now. Some of the funders do look for you. And on the other hand, some of the grants you have to keep applying for. Like they say, there are many that you have to apply for to get your first one. And the important thing is not to be discouraged. Just keep trying. And also trying to hone your question, refine it better, look for the innovative areas that you can attach to it. I remember when I was writing the TED Fund grant, somebody had advised me that, look, and this was as far back as 2019, make sure that it has a strong either AI or machine learning component. But we didn't know anybody, and yet we put the thing together and we were shortlisted and we got that grant. And that was one of the things that helped us, with our first clinical trial. And by the time we were noticed for the second clinical trial, we already had the fact that we were carrying out a clinical trial, even though we hadn't completed it. So that really spoke for us. So yeah, that's sort of the journey. It's not easy at all. One other important thing is that we need to stop, start trying to look in-house and inwards and diversify the funding portfolio. Luckily, global health is where a lot of eyes are on at the moment, but still, that funding will close up. We need to work towards looking to making our own people in this environment understand why research is important for even them in every way, both altruistically, both biologically, as per our race needs, more of its own research, as well as financially. For the people that have a lot of money, they don't want to see their money just going down the drain. So we have to find a way to make them realize that this can actually make more money for them as well. And I think that those are some of the things that needs to be looked at in terms of looking into funding for research. But apart from that, the altruistic part, the fact that, your people are not going to get better in the far future, there's now something we call precision medicine. And precision medicine only works if you have all the gene types, for every race. If, for example, now, let me stop saying, race is a social construct, but for every ethnic group, as it were. If, for example, now it gets to a point where it's only precision medicine that is, working for most people, we will lose out in Africa because a lot of genes haven't been mapped and a lot of trials haven't been done on us to know what works and what is safe and what isn't. So those are some of the stories conversations we have to have with funders, and to let them know that they need to start putting their money into, where we are, and stop looking at the people that make that we know are obviously wealthy. There are a lot of people that are wealthy that, don't speak out. Let's go and look for them and start convincing them that they need to start funding research. But apart from that, to get the usual suspects, it's important to just do very good work and continue building yourself and continue applying.
All right, thank you very much for that. My takeaway from that is if you are trying to apply for funding, target smaller grants, use the grants judiciously, build on it, collaborate with other researchers, and then you can apply for bigger ones. Thank you so much, Ma, for doing justice to this conversation. If you have questions, you can put them in the comments. We have a couple already. We'll get to them soon. Or you can note them down and we'll take some at the end of this Q&A session. So during the course of the discussion, we've talked about CC3s. So CC3s, Prof is the director of CC3s, and CC3s is Center for Clinical Trials and Implementation Science at the College of Medicine, Lagos State University Teaching Hospital. So,
Lagos
I'm quite curious
University, not
about
Lagos State
how
University, Lagos University.
Lagos
College of
University.
Medicine, University of Lagos is actually the main body.
All right,
But
Ma.
a lot of
So
people
sorry.
make that mistake. We're two different institutions.
Yes, yes, Ma. University of Lagos Teaching Hospital, not the people at Ikeja. All right. So I would like to know how or what distinguishes CC3s from a department in the university setting. I mean, in terms of operations, staffing, funding.
Thank you. So CCTRIS is a center, the University of Lagos. It's a research center. And all universities have research centers. UNILAG in particular has quite a lot. And they tend to be funded externally through grants. So CCTRIS is funded solely by grants that we've received. And luckily, we keep, getting grants before the next one is over. So that's how we've been able to keep CC3s going. We have as we speak, grants up to about 2029. So we just, and they're usually at least 2 or 3 overlapping each other at different points in time. So Citrus is funded that way, and it's also staffed independently of the university. At the moment, we have about 27 full-time staff in Citrus. Thank you. Over.
All right, Ma. Thank you for that response. Moving on, we are slowly coming to the end of the conversation because of our time. So many of our listeners here are early career researchers, clinicians who are, interested in research or interested in, developing more on their, already acquired research skills. I would like to know what you would advise that we do. I consider myself one of these early career researchers. How do we identify and choose a strong and meaningful research question?
That's very good. Incidentally, as there's so much that hasn't been answered properly or in medicine. One of the, and I'm talking about medicine because that's what I know. One of the easier ways to identify questions, if you're a clinician, just keep, when you're doing your rounds and just keep thinking about looking for things that don't have answers. The other way is that relatively easy way is to look at guidelines. Most guidelines on any topic have answers, questions that haven't been answered within the research, within that topic, that area. I recently chaired the guideline development group for managing sickle cell disease in pregnancy, WHO guideline development group. And I know that we have a lot of questions that need to be answered at the bottom of that GDG, that guideline. So that's another way, looking at guidelines in the area that you are interested in and seeing what the questions are. Another way is to look at research that has been done in the area. Just read research, individual papers now, not necessarily individual, well-written, high-quality papers. And look at what their answers are. A lot of people would still end it with, future research needs to be done in this area. Now, they don't, if you just say needs to be done in this area, that's not a very good ending. And most high quality papers won't do that. They will specify, the type of work that needs to be done. And that was actually what started my own journey when I was looking at sickle cell pregnancy in particular. One of my mentors had, a paper that I really thought was a very well carried out research project. As far back as I think that paper was written in 1990 something or 1980 something, and I picked up on it because there was an unanswered question there, and I worked on answering that question. And that was where the sickle cell thing came on. And at that time, they were looking at plasma volume in sickle cell pregnancy and trying to find out why the plasma volume did not expand during pregnancy, and they gave possible reasons. So I took it from there, and the work built up from there. So looking at what has been done before and seeing the questions there, looking at your own clinical experience and also guidelines. Now, one thing I didn't remember to mention, which most people talk about a lot these days, is mentoring and looking for mentors. But you do have to realize that mentors are very tired now, especially in this environment of ours where there's so much going on and there's so few people to inspire. Having said that, it's still important, but to be a good, to be mentored properly, you have to be a good mentee yourself. You have to go and meet people who you want to mentor you with questions and, don't waste their time. look for an appointment, you say this is what you'd like, and let them tell you their help you the way they can. But not that you just be sitting down, and some people will be like, oh, I want you to be my mentor, and then maybe they expect you to call them to come for dinner somewhere or something. It doesn't work that way, unfortunately. But mentoring does help, and also you also be ready to mentor people. It really does help. Thank you, over.
All right, ma. Thank you very much. I had to bring out my pen and jotter for that. Thank you. So, we are slowly coming to the end of this session. I'm moving to a more personal question. Your career path is quite inspiring, to a lot of us, and I know you completed residency abroad, then you chose to return to Nigeria. I'd like to ask what informed that decision, and how has it influenced your career? I mean, and also retrospectively, were there things you could have done better or steps you could have taken?
You think I could have done better? Question. That's interesting. So regarding what influenced the decision, it was pre-planned. I never, planned to get lost in the global north. From when I was in university, I knew that I wanted to be part of the answer to Nigerians' healthcare problems. And so I only went abroad because it was easier to specialize and quicker to specialize for me there at the time. So I did, and I planned that as soon as I was done, I would come back, and I did. I think for me, it's always just been that's main thing. Something I beat the patriotism bug in Ife, which was a really, really wonderful place to study in at the time. University of Ife, because we mixed with all sorts of people. We had all sorts of inspiring lecturers, and the campus itself is very cultural and artistic and really, really beautiful. I loved my time in Ife. And I used to read a lot of other things that weren't medicine. I was just exposed. We were all very exposed to so many other interests in life. And for me, it wasn't just, there are a lot of my classmates also did go to the UK then and stayed in the US, although it wasn't a tenth as bad as it is now. But it was never for me, and so it was pre-planned to go and come back. I think my motivation, the things are different now. Everybody wants to blow quickly. There's the Instagram world or the Twitter world, as it were. So you want to be to have reached there as quickly as possible. There's very little patience, and I think that's part of the problem. But there's nothing wrong with wanting to be comfortable and to have money. I definitely don't feel, especially when you've studied so hard for so long. But I think being able to, you can have the best of both worlds by really working diligently here, and that's one of the things that I feel that I've been able to do. I don't even see myself as a returnee now, because I've been back I only went for about 4 years actually, and I've been back for over 28 years now. And thinking about what I could have done differently, there are certain clinical skills that I think I would have liked to learn better. So that's the only thing that I would think I would have changed and paid more attention to them when I was there, in terms of minimal access surgery in particular, which I now had to start learning properly when I got here. There was a lot of it going on there. But in terms of research, I don't think I would have done it different. Perhaps I could have done maybe like a master's in public health at some point, but now I'm almost a public health physician myself with the people I affiliate with. So Really, yeah, I think one of the differences would have been maybe spent more time, more dedicated time learning research methodology, that it would have been more natural. But I picked it up as I went along and did a few certificate courses here and there in biostats and epidemiology, and I tried to make up for it that way. So yeah, that's me in a nutshell. I never, it wasn't a decision I made when I got to the UK. It was a decision I'd made before, and I stuck to it, and I haven't regretted it ever.
So, Prof, PhD or residency?
That is a very tough one. Oh, Kai, that's tough, especially since I have both. I don't know. I think it depends on what really makes you tick the more. Yeah, I think that is the correct question to that. I think that if you know that research makes your blood boil, forget residency and just do your PhD and move on. But if you know that you really do like clinical work a lot, then do the residency. Do the residency first, and maybe close to when you're finishing, start doing some, other. You can work towards doing a PhD. But yeah, I would say it depends on what really makes you tick.
All right, Ma, thank you. So at this point, we'll open the floor for questions from the audience. So if you have a question, just request for the mic and I'll invite you to speak. But in the comments, we have a couple of questions. I would read out one from Dr. Femi. He said, did you get some data on other medications that could potentially affect absorption of oral iron in the oral iron group? Then there's a follow-up question on okay. He'd like to know if and how compliance with oral iron was measured.
I didn't hear the compliance question properly, and I can't see it here. I can see the other
Okay.
medications that could potentially affect.
Yeah, the oral iron question is that he wants to know if and how compliance with oral iron was measured.
Oh, I see. Yeah. Yes, we did measure compliance. Yeah. And there was about 95, 96% compliance with the oral iron. Don't forget that this is a trial. That's not usual practice. In usual practice, you would not have the women taking it as much, but because it's a trial and follow up, the people, asking them to bring their tablets back to the hospital and blah, blah. Yeah, there was compliance. That's how it was measured by pill count. That's how we measured the compliance. Now, data on other medications that could potentially affect absorption of oral iron. No, we just told both groups, whether they are on oral or FCM, to avoid certain things and to take the iron. The people that were on oral iron, we told them to take the oral iron an hour before food or 2 hours after. And we gave them all vitamin C. So we did our best in that regard. No, we didn't look for data on other medications. We told them not to take any other medication apart from what we were giving them, as well as also to make sure to tell them to take the oral iron 1 hour before their meal or 2 hours after, when we expect the stomach to have emptied, and so that it doesn't affect it any longer.
All right, thank you, ma'am. Adesoji Yusuf, you requested the mic earlier, but I don't know.
Just apply online. You can apply online. I've seen the question. Chances to intern with CC Trace. There's an online application. Just apply for it. Apply there, and you'll be responded to. In case you're not, most people will be responded to. I mean, there's an info and CC Trace address. In case you're not, just come to the College of Medicine, to the CC Trace office, and ask for Rachel.
All right, ma, thank you. Are there any more questions? I can't see any more questions. Okay. So before we wrap up, Prof, what final advice would you like to give young researchers and clinicians who hope to make meaningful impact through research?
Just please keep believing in yourself, even if you don't get the grant at first. Keep working on honing your skill, making yourself better. working at your on your skills in terms of research methodology. And also, one good thing generally to everyone, whether it's research or not, be a citizen of the world. And you don't have to travel anywhere to be a citizen of the world. Just open your mind. Sometimes you get bogged down with so many things and issues in Nigeria that you forget that the world is not just that small space you live in. Read other things apart from your area, think broadly, think widely, make your mind progressive. All those things help. You won't know where you get the connection, to do certain things, but just try and keep that extra time to, if you do 80% of whatever your field is or your research is, keep at least 10 of the other 20% so for exposing your mind to a lot more. So those are the little snippets that I would mention.
Thank you so much, Ma, for that. We have one final question. I'm so sorry. From Dr. Femi. So he wants to know what you did for the women who got ill during the trial period. Did they have to attend LUTs, or were you comfortable with them seeking care elsewhere?
Not at all. No problem with the question. So don't forget that we recruited these women in many different hospitals. It wasn't just Luth. In fact, Luth was only one of the 20 institutions where the women were recruited from. We used primary health centers as well. Primary health centers, secondary health centers, and tertiary in all the states that we were in. And so if they got ill, they reported back to where they were looked after. That was it, basically. And we all supported them with whatever, they needed during the illness.
All right, Ma. Thank you so much, Prof. Afolabi, for sharing your time, experience, and wisdom with us this evening. And thank you to everyone who joined our first ever community talk. We have so much more planned, and follow us to stay updated. You can follow Prof too at Cool Gyne. Follow CC Tris. They are doing amazing work over there. So thank you so much, everyone. Have a wonderful evening. Bye. Thank you, Prof.
Thank you. Thank you very much. Hope we got something from this. Have a nice evening and compliments of the season to everyone. Thank you for inviting me.
Same to you. Thank you, Ma.